families to establish realistic future goals. Let's figure out what the child likes and what vocations can the child realistically do that they also have an interest in. And then, prolonged survival rates of these kids. They used to not survive into adulthood, but now they do. So we've got a whole new set of problems that you'll be seeing in your adult nursing. How do we help these kids to live independently? What about marriage, employment, insurance? We know they're going to need a lot more health care than the average person. And what about reproduction? In the past, these kids didn't live to consider reproducing. And, those are ethical questions that, are now coming up. Okay, end of life care. When you have a kid who's dying, anytime you lose a family member, it's hard on the family. It's harder when it's a child, most of the time. So, principles of palliative care is that we always want to focus on pain control. That is the biggest emphasis at end-of-life care, is keeping the person comfortable, whether they're an adult or a child. Then, decision making. Are they going to be do not resuscitate, do not intubate? I've seen some muscular dystrophy kids where we knew they were near the end of life, there really was no hope, but the family just couldn't make the decision, do not intubate. That's hard. Ethical considerations. The American Nursing Association, their code for ethics for nurses says that it is okay to withhold or even to withdraw treatment if that treatment is going to cause pain and suffering to a dying patient. Most doctors, most nurses are very comfortable with not starting treatment when somebody is at the end of life, whether they be an adult or a child. Many are not comfortable with withdrawing care. So once we've intubated a child, if the family says, like that muscular dystrophy child, there is no hope, now we just are making them uncomfortable, this was a bad decision, pull the tube out, that's just a lot harder for doctors and nurses to do. It gets done sometimes, but I think it's emotionally harder, and it's legally a little bit shakier, and so a lot of doctors don't want to do it. Decision making. Ideally, this is a team working together where it's really nice if the parents and the child, most children, unless they're really small, they understand they're dying. So it's good to have them part of the discussions of what they do want and don't want. And then the health team. It's nice when everybody can work together and be on the same page, but legally, if everybody's not on the same page, the parents are the ones who legally get to make that decision. And as healthcare professionals, it's our job to support those parents and follow their decisions, even if it's not the one we would have made for our child. And just personally, the years I worked in Pete's ICU, the way I handled that was I would tell myself, I may go home upset and have trouble sleeping for a night or two, but that's all. These parents have to live with this decision the rest of their lives. If this is the only decision that will allow them to live without a lot of guilt and second guessing for the rest of their life, then I can do this for them. And, again, it isn't going to be as hard for me long term as it is for them. So I would follow their decision, even when sometimes they made a decision that would not have been mine. Okay, when you have a terminally ill child, just like with adults, you can have them in the hospital to expire in the hospital. You can have them at home with just home health nurses coming, home care, or you can have hospice involved. I would say hospice, unless the family is against it, is pretty much always the best choice. Again, that's my personal opinion, but hospice is really good. Their caregivers, well, their nurses will come and teach the family what they need to do. The family really does a lot of the care, supported by the hospice team. Hospice is always primarily concerned with comfort, but they're concerned with the whole family. They look at the needs of the whole family, not just the patient. And they'll continue to check up on that family for up to a year. My understanding is they call it at certain intervals, and if the family's not doing well, they can call the hospice nurses and, talk to somebody more frequently than what the nurses do. They have a lot of support groups that they run for people who've lost someone. Anyone I know who's had to use hospice to lose, when they've lost a loved one, they've felt like it was very helpful. Okay, pain and symptom management. I said pain, that is our highest priority when we're talking about end of life. We want to keep people comfortable, which means we're probably putting them on pain medication around the clock, and then we give them extra pain medication when they have breakthrough pain, when we're not controlling it with that round-the-clock medication. Now realize when you're on an opioid, you develop a tolerance to it, so it takes more and more medication to reach the same level of pain management. So sometimes children will end up on very high doses. That's required to keep the pain under control. And pain, that is one of the biggest problems when kids are dying of cancer. Pain control is very difficult. So fears at end of life. Kids who are nearing the end of life, of course it depends on their developmental level, but usually what they're afraid of more than death is they're afraid of pain. They're also afraid of dying alone, and the parents are afraid of not being there at the actual time that a child dies. And just in my experience, people tend to take longer to die than the family expects. When the family starts seeing them do poorly, they all come and they stay around the clock at the bedside, and it often takes longer than they're expecting. And at some point they've got to go home, they've got to shower, they've got to get clothes, but they don't want to leave because they don't want the child alone when they actually do expire. So that can be difficult. And for many kids, they are afraid of the actual death. And this is where, home versus hospital, it really is good if we can get the child as part of the discussion, because the child may want to die at home. They may want to be in their own bed, surrounded by their own things in their own room. And the parents may not be comfortable with that. So this is where you're really going to need a social worker to help out and, find something that everybody's comfortable with. Here's a picture of a little boy, I assume boy, I don't know, a child, probably dying of cancer, because of the lost hair. Okay, grief and mourning. It's normal to grieve when you lose someone. It's normal to go through all sorts of somatic distress. You can't sleep, you can't eat, you can't concentrate. You feel preoccupied with thoughts about the person that you've lost. And then you feel guilty. What if I had done this? What if I had tried that? What if I had only, and parents are good with guilt anyway. And when it's a situation where you've lost a child, it's even easier to throw guilt at yourself. Hostility, being irritable with people, being annoyed, being frustrated, being hostile. And just you lose your usual patterns of conduct. People are not at their best, they're at their worst, and they can't sleep and they can't eat, and just everything is out of whack for them. That's all normal grief. And we can reassure parents that the things they're feeling are normal. But sometimes grief is not normal. Sometimes it becomes complicated or abnormal. And that's when somebody really needs to get a counselor or a professional involved to help them get through this so that they can get back to their normal patterns of life. And how long does that take to get through grief? Most parents who have lost a child will tell you, you never get over it. You learn to control the pain, you learn to get on with life, but you're never totally over it. That's what they say. And what I've had people say is, you expect things like their birthday to be hard, or special days. If their favorite place was the zoo, going to the zoo will bring up memories. And so you emotionally gear up for those, and you get through them, and they're not that bad. It's the days you weren't expecting. The time you run into a little girl who's wearing the same dress that was your daughter's favorite. The times that, you couldn't have anticipated, that those tend to be the hardest, where the grief really comes back. How about nurses? When you lose a patient, it's hard on the staff too. And the kids we lose, most often they're the oncology kids, peds ICU, and ICU. A lot of them have a long hospital course. The nurses get very attached to the child and the family, and the nurses go through the very same sort of feelings of guilt and what could I have done? I should have done. They get angry, they get frustrated, they may not be able to go home and sleep or eat, or they may have those very similar feelings. And I'd say, try and focus on the positive. We did the best we could for this child. We gave that family and child 2 extra years together by treating the cancer. We may have lost the child, but I'm sure the family would say it was worth it to have those extra couple of years. Funeral services. I know some nurses and some of the social workers at Children's I know go to funeral services regularly. They feel like they need it for closure, and they also feel like it, tells the family we're grieving with you, we're sad along with you. I have never gone to a funeral service for a patient. I felt like that's where I needed to separate my life from my job. There's been several times I really considered going and decided against it. So I think that's a personal decision, and you just need to know what's going to help you to get through losing that patient.